Okay, welcome to our 50th episode of Urology Exam Preparation. This is our mock viva episode 5. We have 4 trainees volunteered to take part in this session. We are going to discuss 4 stone related scenarios. Thank you for everyone for joining. The first trainee will take the first scenario. Your time starts now. You have a 32-year-old gentleman presents with history of generalized abdominal pain, lateralized more towards the right side. He is suffering from this pain on and off. He has no medical illness. How are you going to evaluate him?
So I will see him in the clinic, and I will take a history to find out more information about the pain. I also want to know whether he's got any urinary symptoms, whether he's got any confirmed urinary tract infections, and I want to know whether he's had any history of stones in the past. I will also ask about his comorbidities, performance status, and drugs. I will then examine him, checking his observations and loin tenderness. And there in clinic, I will do a urine dipstick with or without urine culture, and I will request bloods and upper tract imaging.
Okay. So, what is your working diagnosis?
So with the recurrent pain, it's possible it's got a stone, either in the renal pelvis or in the ureter. The other alternative could be pyelonephritis.
Okay, so what kind of imaging you are going to plan? Let us assume that examination is normal. Urine dipstick showed 2 plus leukocytes, no nitrites, no RBCs, no other findings. His bloods were all normal except for CRP at 12.
And does he have any previous history of stones?
No.
So I could start with an ultrasound scan of the renal tract, but if that is normal, I will have a low threshold to progress to a CTKUB.
Okay, his ultrasound showed right-sided mild to moderate hydronephrosis, left kidney normal, bladder empty.
So in that instance, I am worried he may have an obstructing ureteric stone. So I will arrange CTKUB.
Okay, why CTKUB? Why not Ct Eurogram?
Because I'm particularly interested in stones. And we know that the sensitivity of non-contrast scan for ureteric stones is more than 95%. So in that instance, I would do non-contrast CT.
Okay, any specific protocol for CTKUB?
It's just there's no particular protocol. It's just the non-contrast phase.
Okay, he has his CTKUB done. I'm going to share the images now. Are you able to see the pictures now?
Yes.
Okay, I'm just scrolling from top to bottom. You can start dictate as you see.
Okay, so grossly normal liver, both kidneys coming into view, mild right hydronephrosis, left kidney looks fine. I cannot see any stones on either side at the moment. Right ureter is slightly dilated, and I'm following it down. Right ureter is still in view, still a bit dilated. Left ureter has disappeared, which is good. And I'm still following you. I cannot see any. Yes, so there is a small, probably 6 millimeter stone in the distal right ureter. Okay. Yeah, so there is a small distal right ureteric stone.
Okay. Yes, the report also says right-sided lower ureteric stone measuring 7 millimeter, approximately 1 centimeter from the VUJ. No other stones noted. No other significant findings noted. Mild to moderate hydroureteronephrosis of the right kidney. How are you going to manage him?
So his blood, please, and his renal function, is it all normal? And
Okay, as I said, his bloods were normal except for CRP at 14. Everything is normal.
so I will give him safety net advice and manage him initially conservatively, expecting spontaneous stone passage. We know from the mimic data that a lower ureteric stone of his size has an approximately 50% chance of spontaneous passage. If I'm not able to see the stone on the scanogram, I will request a plain X-ray KUB before I discharge him, just to see whether or not the stone is visible. But that will help me to follow him up in the clinic. I will then see him in clinic in about 3 weeks to see whether or not he's passed the stone. In my practice, I will send him home with a trial of tamsulosin because it's recommended in the EAU and in the NICE guidelines.
Okay, what dose of tamsulosin? How are you going to explain this to him?
So I will give him 0.4 milligram of tamsulosin. I will explain to him that the use in distal stones is controversial. Some studies have shown that it is not beneficial, while some other studies and meta-analysis have shown that it has some benefit. I will explain to him the use is off-label, and I will inform him about side effects such as postural dizziness, retrograde ejaculation, and increased stuffiness of his nose while taking the tablets.
Okay, he has got pain even before discharge. What other medications advice you will give him?
So the NICE guidelines recommend non-steroidal anti-inflammatory drugs, which can be combined with paracetamol as first line, and second line definitely will be opioids. If I'm not able to get on top of his pain, then that will be an indication for admission, and I will aim to treat him within 48 hours in that instance as recommended in the NICE guidelines.
So, what NSAID you are going to prescribe him?
I will give him diclofenac suppository. In my practice, I normally will use 100 milligrams per day.
Okay, any advantage in suppository compared to oral tablets or intramuscular injections?
So it's just the fact that the suppository bypasses the gastric, the risk of gastric ulceration and gastric irritation is bypassed. So that's the main advantage of the suppository.
Okay, what is the dose?
The diclofenac suppository, I would normally use 100 milligrams a day.
Okay, so you are going to see this patient in 3 weeks' time. You're seeing the patient. Patient is relatively asymptomatic. He had symptoms of on and off pain for almost 1 week, but the later 2 weeks were quiet and he's comfortable. What is your plan?
So I will repeat his X-ray KUB when I see him to check whether or not the stone is still present or it's gone.
Okay, what is the radiation dose for one X-ray KUB?
It's 0.6 millisievert.
Okay, the X-ray KUB done is normal. What are you going to advise him?
So if the stone was previously seen on his X-ray 3 weeks ago, and on the repeat X-ray in clinic the stone is gone, I will then give him fluid advice using the Bowles information leaflet. I will inform him he's got up to 50% risk of further stones in future, so he needs to increase his fluid intake at least 2.5 liters per day. He should also take normal balanced diet, avoiding excess protein, excess salt in his diet. I would also, if this is his first stone, I will make sure I check his calcium and his urate, and if they are all normal, I will discharge him back to the GP at that point. If he's from, if he's a if he's a high risk patient, meaning he's had more than 3 stones in the last 3 years, or he's got a strong family history, then I could consider further metabolic evaluation.
Yeah, can you hear my
Yes.
alarm?
Yeah. Thank you. Okay, well done. We'll stop the discussion here. Good presentation. I'm happy with the way by which you have taken the scenario. Your expression of words and communication is quite optimal. This speed is very good. It will be very useful for some examiners to hear and understand your words. So some trainees I find speak a little bit faster. Even I speak sometimes faster, but your speed is very optimal. So please keep up the speed and keep up the noise level. The volume is very good. And positive things, you thought outside the box, you didn't really focused on the stone, you thought about infection. That's a positive thing. You have brought in nice guidelines, Bowes leaflet, mimic trial. That's very good. And overall you haven't deviated much from the normal protocol. That is very good. And I will say the negative things are, number one, usually it's not a bad choice to do CTKUB directly even before ultrasound. And it's debatable because you had a small doubt of possible pyelonephritis. As I said, the urine dipstick showed only leukocytes, no nitrites. So that may have led you to do CTKUB directly. I'm picking on everything, so don't take things very seriously. But if you are able to concentrate on this, it will really improve your performance further. So you may have gone for CTKUB directly, and you need to quantify the CTKUB. It is a low dose CTKUB if the patient's BMI is less than 30. So be very clear in what you're asking. If it is BMI more than 30, there is no place for low dose. It should be a normal CTKUB. That's why I asked you the CTKUB radiation dose and other things. And I'm happy with your normal history taking, except for the fact you haven't asked about the occupation. Because if the patient is a lorry driver or pilot or something very specific, you need to be very careful in counseling the patient, or you may have to ask the patient to take enough break from the job. It's nice if you have asked that. Your reading the CT scan is quite good. I'm happy with that. There is no question in that. And in exams you may not have such a detailed CT scans. It may be only 1 or 2 cuts, but I'm sure the exam will progress so that they will show you the full CT scan mimicking the real life experience. And I'm happy with your tamsulosin tablets. Whenever you are prescribing tamsulosin or even thiazides for medical management of stones at any point, you should mention that these tablets are prescribed out of license. They are not licensed for the medical management still. So you should say that, because by chance if the patient had a hypotensive episode, fallen down, break his head, ended up in ITU with a cranial hemorrhage, he may sue you that you have prescribed a medicine which is not licensed for passage of stone, even though you may have a good amount of evidence backing you. So you should mention about the non-licensed prescriptions for tamsulosin, even for thiazide diuretics if you are prescribing for other reasons. You have brought in NICE guidelines few times. You should be able to say NICE guidelines 2019 comfortably, because you know it's a very recent guidelines, so try to mention the year. Similarly, if you're mentioning EAU guidelines, try to mention 2021. We have the latest guidelines now, even though there may not be a major change between 2020 and 2021. It's nice if you say the year, which will keep the examiner happy that you are quite updated. I'm happy with your evidence showing mimic and also the nice guidelines, but it's nice if you bring in the suspend trial, because it's a UK based trial, and the suspend trial really ruled the FASIS exams from 2014 till 2018. And in fact, the correct answer for the exam is not to give the tamsulosin, and then everything changed with the other evidences, and nice also approving the tamsulosin tablet. So some examiners may be still holding on to suspend trial. So you can say there is a trial which didn't support it, but my overall uh, um, correct method is giving tamsulosin. Giving tamsulosin is absolutely correct. You didn't brought in painkillers. You stopped with tamsulosin and progressed. I only asked you a prompt question of painkillers and how will you do. I'm very happy that you are very particular in making sure that the stone is radio opaque in a plain X-ray, and you are looking at the scout film if not doing an X-ray. That's a very good practice. Other than that, I'm happy. It's a very simple scenario, but you can see even in simple scenario, you may felt you have done very well. There are few things still to be done, and 3 weeks clinics sometimes is very challenging. You need to be very sure that you have enough capacity for that. So how I will answer is, I prefer to bring this patient within 3 weeks, but sometime because of NHS capacity it may end up in 4 to 6 weeks. Even if the patient is asymptomatic, you should do an X-ray, especially if it is a radiopaque stone, as you know already. There is a 30% chance that asymptomatic patients on follow-up may have still stones. The kidney, because of the repeated colic episodes and peristalsis, have gone little bit atonic, and so the colic episodes may have stopped, but the patient's stone may be still there. Yeah, this is my take home. I will say your mark easy 7, and if you can satisfy all the points what I mentioned, it will be a definite complete 8. Okay,
Thank you very much.
good. Any questions you have before you leave?
No, thanks for the feedback. It's very thorough. Thank you very much.
Very good. Okay, we have got our second trainee, and we are going to start the second scenario. Your time starts now. A 45-year-old gentleman presents with history of right-sided loin pain, and he was previously evaluated and found to have right side upper ureteric stone, and he has got his CT everything done. He is presenting to you second time via A&E. What important features you will look in the history?
First of all, I want to make sure the patient is comfortable. See, it's an A&E presentation. Whether he is known to have stones in the past, he has family history of stones, any features of infection at present, any history of recurrent urinary tract infection in the past, any abnormality, any anatomical abnormality in his renal tract system, his past medical history, his drugs and allergies, whether he's taking any anticoagulants,
Okay.
and his occupation as well.
Okay, just my apologies. It's a left-sided pain. Otherwise, everything is correct. Okay, he's not on any anticoagulants. He's got severe left-side pain. He's quite symptomatic, and nothing in the past history except the once history of presenting 2 weeks before with similar left-sided ureteric colic treated conservatively. His urine dipstick today showed 2 plus nitrites and 2 plus leukocytes. Nothing specific otherwise. His blood parameters were normal except for CRP increased at 120. His previous CRP during the last presentation was 20. Okay, what are you going to do?
So I suspect that this patient is having a UTI or sepsis. So I would initiate a sepsis pathway if QSOFA score suggests a sepsis. I would take the A&E physician to manage this and also his pain management. I would like to have an imaging to see where the stone is still there and if there's any upper tract dilatation.
Okay, I'm going to share the screen. You can see the images now. Are you able to see the images?
Yes.
Okay. I'm going to scroll from the top so you can dictate as you
So this
see?
is the axial film of the abdominal CT. The liver is normal. The right kidney looks normal so far. There is a hydronephroureter on the left kidney with sort of thinned out parenchyma. There's upper ureteric stone. Um, and yeah, the ureter was dilated until the stone. The rest of the ureter I couldn't trace on the left side. As we go down, the bladder looks normal. However, I would like to see the other images as well to measure the stone and to measure the Hounsfield unit as well. Yes, so this is the coronal pictures of the same CT scan. So this shows an upper ureteric stone, which is obstructive with the hydronephrosis with very minimal fat stranding on the left side. I would say this is around 7 millimeter stone.
Okay, so what are you going to do?
So the patient is in pain and his CRP is high. So this is a infected obstructive system. So I would like to, my plan is to decompress the system. It would be either retrograde stenting, cystoscopy and retrograde stenting, or nephrostomy, depending on the patient's fitness for anesthesia and availability.
Okay, how will you choose between stenting or nephrostomy?
We have evidence from Pearl et al. Paper that both are similar in terms of de-obstructing the system and treat the infection. So my point would be to see whether he is fit for anesthesia, and if he is fit, if the anesthetist is happy, my first choice would be a retrograde stenting. That is my usual practice.
Okay, what factors you will think for the fitness for anesthesia? Any other things you will discuss with anesthetist before taking him under anesthesia?
His hemodynamic stability. I know he is not on any anticoagulant medication. His past medical history is not significant, and his hemodynamic stability is the one which is important. He is not very obese patient from this CT I can see, and the rest the anesthetist will see the factors which intubation. So I think if they are okay, I will go ahead with that.
Okay, you are discussing the pros and cons of stenting versus nephrostomy with him, and after explaining everything, he preferred local anesthesia procedure and to avoid GA. So, how are you going to counsel him?
Okay, I would tell him that this procedure is done by my interventional radiology colleague in the interventional suite. It is done under general anesthetic. They might give some sedation. So the procedure involves passing a tube to the kidney directly. So the other alternative is the retrograde stenting. I also would tell him we have an option to put a stent antegrately at the same sitting or a little later. The complications include a bleeding, infection can happen, and patient will have a bag hanging out, so that might be a discomfort for him. And also injury to the bowel when the procedure is done is a rare but possible complication. And I also would tell him that the discomfort he has with the tube, and also if we did an antegrade stenting, he might have stent discomfort, pain, and infection, recurrent infection. And also I would tell him that this is not a treatment for the stone at the moment. He will later have a treatment for the stone with some other means.
Okay,
so I also would give him a pause information leaflet on that. Yeah.
Okay, he had his nephrostomy done, and this is the first picture of puncturing the kidney. You can see the upper ureteric stone, and after checking with the contrast that the needle is in place, he had his nephrostomy done. He is stable. He is recovering from his nephrostomy. The nephrostomy initially drained purulent urine, but later cleared in 24 hours. So how are you going to treat him further?
This patient will have antibiotics based on the trust protocol and his culture report in consultation with microbiologist if required. My usual practice is to give coamoxiclav and IV gentamicin if the patient is not allergic to any of this. So a patient will have a regular monitoring of his bloods and his hemodynamic stability. Once the patient is improved from his infection and sepsis point of view, I would discharge him. I'll give him the option to have antegrade stenting if he wishes. I'll speak to my interventional colleague to the could integrate stenting. Then the definitive management of the stone will be planned. So if it's a very good radio opaque stone, so ESWL is an option for him. I also give him the other option of ureteroscopy, semi-rigid / flash flexible ureteroscopy, and laser tripsies. Based on his preference, I would take it from there.
Okay, so let us assume this patient prefers plan A of keeping the nephrostomy till the definitive treatment, plan B having an antegrade stenting. If he prefers plan A or plan B, will it change your stone management protocol?
If I'm planning for ESWL, I would prefer to keep the nephrostomy because we know according to the 2021 EAU guidelines, they don't recommend put a stent if a patient is planned for ESWL. So in that case, I would prefer to have the nephrostomy in situ.
Okay, why the stenting is not preferred for ESWL patients?
Because of the presence of the stone, even if it is fragmented, the clearance is less when they have a stent. So for that reason, we prefer not to stent before planned ESWL treatment.
Okay, why the clearance is not good?
The way the urine drains after the stent will not allow because already the stent is there within the ureter, so the size of the ureter, the diameter of the ureter will not allow the stones to pass.
Okay, so how the urine drains in the presence of a stent?
The majority the drains around the stent, and only a small amount drains within the lumen of the stent. So it's around the stent. That's the main way of urine drainage when there's a stent.
Okay, so this patient, let us assume, preferred to have ureteroscopy. So how are you going to counsel him?
I would tell him the aim of the procedure is to pass a camera through the water passage and to remove the stone. We break the stone probably with a laser, and then we'll remove the stones out. The alternative is ESWL. The complication associated with that is infection and bleeding in short term, and the injury or damage to the ureter is a possibility, although it's rare. And there's a risk of stone retropulsion, failure to complete clearance, which might need further treatment in future. And also, I would tell him we might leave a stent at the end of the procedure, which might cause
It's 10 minutes.
Okay, very good. We'll stop there. Good. How did you perform? Any feedback from you before?
My answer is very short, so I don't know whether my plan was to answer only to the questions asked, but you had to ask so many questions. I don't know whether it comes as prompting or additional questions.
No, I won't say that I did prompting at any point, except that I preferred you to keep both the options of nephrostomy, going for ESWL, or antegrade stenting and going for ureteroscopy. If you have brought it on your own, that will be a good one, but I didn't really prompted much. Okay, you have anything to say before I give you the feedback?
And the way the ESWL, the urine drains, I don't know whether it was okay. It was not very, it didn't come out very well, I think. Anyways, I'm waiting for your feedback.
Yeah. Okay, again, a nice presentation, good communication, clear words, and good pace. I'm happy with the pace, so you don't have to change anything on the volume of the answer. I mean, loudness in the answering and pace. That's perfect. Just keep it as it is. You have taken the scenario well, and left ureteric colic because of the previous episode. You are able to retrieve the previous CT scans also, that you may have to be very clear in saying before you repeat in another imaging. When you are repeating the imaging, maybe initially an X-ray KUB is enough if the previous CT KUB is quite clear. And as we discussed in the first scenario, if it's a radiopaque stone, it's nice to have X-ray KUB to start. And I'm happy that you picked up that this patient has acute infection with the help of the urine dipstick results, what I said to you. You picked up the hydronephrosis, and when you're deciding between the nephrostomy and stenting, I slightly differ in my choice. Again, it's individual, but your answer is perfect. But if I explain to you why I differ, maybe you may change or you may take my answer. Number one, stenting requires GA. Nephrostomy, it can be done under local. Number one. Number two, if it is really a thick purulent pus, maybe a nephrostomy is a touch better in giving a better drainage compared to the stenting. Number three, if you do a nephrostomy, your options of ureteroscopy and ESWL are both open, while if you do a stenting, you may more deviate towards the ureteroscopy because the ESWL is not very optimal in a patient with stent, which we will discuss further. So in my practice, I will try my best to use intervention radiology suite support to do a nephrostomy, and I'm happy for straight away antegrade stenting or elective antegrade stenting after 24-48 hours, and I will keep the GA retrograde stenting only as a second option in case if there is no IR suite slots available or IR person not available, etc. But you have chosen the retrograde stenting as a first choice. Not a bad choice, it's just my personal preference, and I have reasons which I should tell you. So for the trainees, whatever you choose, if you substantiate with good reasons, that's good. The examiners are happy even if the answer is exactly opposite to what the examiner is expecting. And if you have a stent in place, if you read through the guidelines didn't really say that presence of stent will affect the results of ESWL. The guidelines really says if you are planning for ESWL, there is no need for a planned pre-stenting. That's the main sentence from the guidelines. But we all know in the presence of the stent, it is a foreign body. As we know, when the shock waves pass through during the ESWL, it will be easily going through the fluid medium, gel medium, skin, subcutaneous tissue. But when it comes across the stone, there is a stoppage of the shock waves, which results in fragmentation of the stones. And the stones can also, reflect the shock waves. So presence of a stent causes the same problems with breathing. You can't focus the entire shock waves in the stone alone. So the shock waves will reach the stent, which can cause two main problems. Number one, it is unnecessary wastage of shock waves on a foreign body. Number one, in the same thing, it will result in unnecessary distraction of the shock waves. So you won't be able to have the maximum shock waves on the stone. And the second main thing is if the performer is not very focused and just distracting the shock waves, it can cause stent fracture, and which is a headache, and you need to do a ureteroscopy to remove the stent. So these are all the practical constraints in doing ESWL in the presence of the stent. If a patient has stent, it's always nice to do ureteroscopy. Why? Number one, stent will create a nice dilated ureter, so your success of ureteroscopy, whether it's a semi-rigid or placing an access sheath, using a flexible ureteroscopy and clearing the stone in single sitting is relatively high in a nice dilated ureter due to the presence of the stent. And so the chances of you doing a single anesthesia procedure, retrograde ureteroscopy, which means both semi-rigid and flexible ureteroscopy, and clearing the stone, and if the ureter looks good, you can even make him stent free. You can do no need to place the stent in a pre-stented patient, especially if the ureter looks good. So the efficiency will be better for ureteroscopy if the patient is stented compared to a non-stented patient. It's quite clear. So initially decide quite clearly whether you want to take the patient to nephrostomy or stenting. In my hands, patient with significant symptoms, fever, increased CRP, urine shows positive signs, I will try to lean on nephrostomy, and I will choose retrograde stenting as a second choice. Once the patient had nephrostomy, if you have slots, go ahead with ESWL. If you have stenting done by any means, try to go for ureteroscopy. That will give you a better clearance. Okay, are you able to understand what I mean?
Yeah, sure.
Perfect. Again, I will say the mark easily 7 or 7.5. Very small changes. Again, when you're saying nice guidelines, you can say nice guidelines 2019, and you brought in at least one reference. That's very good. I'm sure there will be further improvement from here. Okay.
Okay.
Good.
Can I ask one thing quickly?
Please. Yeah.
So the stent versus nephrostomy, can I bring in that nice guideline says that patient should be deobstructed within 4 hours in the case of the infection. So depending on the availability,
Yeah.
can I bring it in that?
Yeah, that's a nice choice. For example, in our practice, we have predominant presence of intervention radiologist in the daytime, say 8 o'clock till 5 o'clock, while after hours it will be less available. Yeah, you can use that to support your option of taking him for retrograde JJ stenting. The other main disadvantage of retrograde JJ stenting is there is always a very rare possibility that guide wire will not pass through the stone. This is a good stone. This stone is almost good 8 millimeter to 9 millimeter, and it's a nice heavy high ounce fill unit stone. So if the guide wire is not passing, you're really stuck, because you may have consented the patient only for cystoscopy and JJ stenting. You can't just like that open a ureteric catheter, and there is a small possibility of failure. While with such a nice dilated pelvic calyces system, the chances of nephrostomy placement is very remote. That you can bring in to support nephrostomy. I'm sorry, I'm trying to take myself again to nephrostomy while you are trying to support yourself for
No.
JJ stenting.
That's a good point, actually. Failure is a good point, and the infection pus maybe. Yeah, those two very good points.
Good.
Thank you.
Hi, Mr. Dhanasekaran. Shall I add a couple of points quickly?
Please. Yes.
Yeah. So it was a really good presentation. Everything was quite clear. I particularly like the term obstructed infected system. The examiners are looking for that word. When you see a patient with an obstructed stone with raised CRP and things, so that obstructed infected system is a very important term which you need to say, which you correctly mentioned when you saw the CT scan. The second thing I noted was you didn't initially mention antibiotics, although I know you noted, you told me the sepsis 6, but you didn't specifically mention about the antibiotics before the nephrostomy. That one thing I noted. And I don't know whether we follow QSOFA, the initial assessment, when especially in UK, because QSOFA is only for saying for the mortality in patients who are septic, basically. So I was not sure of that. What is the comment, Mr. Dhanasekaran?
Yeah, that's a good point, Murali. Thank you for pitching in. I will strongly support using sepsis 6. So don't think that sepsis 6 is the word which I have to use for the infection table. It can be used anywhere, even in trust biopsy scenario. If there is an infection, you may have to bring in sepsis 6. Rather than QSOFA, possibly you can use the NEWS news scorings, so that when you say I will keep an eye on his news score to see how his overall score behaves and how he is improving with his antibiotics and painkillers and analgesics. News score is the one which we use regularly in NHS, but we may not be labeling it as news. So from now onwards, when you're doing the morning ward rounds, at least with your junior doctors, what is his news score, especially in a septic patient? That will make you to remember the terms. Yes, perfect. Yeah.
And I completely agree with your nephrostomy versus stent discussion. I think I will go for nephrostomy in this case.
Yes, I mean, practically that is having a better success rate and will definitely give you a better patient related outcome. I mean, if you lean towards nephrostomy, you are really in a very comfort zone and you don't have to really substantiate a lot, because 9 out of 10 examiners will support you and you will progress fastly to ureteroscopy, because this scenario is a ureteroscopy scenario. But you don't know. So you don't know where you need to give heavy weightage. But if you are slightly deviating from something 90% normal, you can still be successful. I'm still giving you easy 7 for this scenario, 7.5 also. But the examiner will have a slight feeling why he's given retrograde anesthesia, JJ stenting straight away without keeping nephrostomy at least as an equivalent option. And that may cause examiner to bring in some question to see whether you lean towards nephrostomy, and if you're not leaning, examiner will think, okay, he's quite clear on stenting, let's proceed. And then that will create a kind of a lacunae which can drop the mark by 0.5, sometime even 1. I'm not telling only about this scenario. Even for all the scenarios, the examiners will be quite lenient if you are deviating a bit. You should not make a big mistake. None of the answers are mistakes. But if we save some time by following the golden path in all the scenarios, you may be discussing more about ureteroscopies, what laser setting you will use, dusting, fragmenting, roll of baskets, access sheet size, so many things we can discuss. But it will not affect your performance. Overall, you will still get good marks, but those who are able to squeeze in and answer and proceed faster and reach that final answers, like what is the complication of access sheath, you can quote Oliver Traxer's paper saying that what is the rate of ureteric injury, etc. And if you reach that, you are 8, and we should attempt that in every table, isn't it?
Yeah. Thank you, Murali.
Very good. When you are in endourology, there are so many evidences, but as I said, in BPH and prostate cancer, the examiners will ask evidence. In other tables, we will not ask evidence, but it's nice to bring in. And you all will be following Twitter and so many posts and pictures from Oliver Traxer, and he has published it also, both in Journal of Urology and World Journal of Urology. Both the journals have got excellent papers on ureteroscopies by Oliver Traxer. So you can blindly say, as per the Oliver Traxer's paper, you can say 2018, 2017. Definitely there will be a paper in those years. Okay?
Yeah. Okay.
Good. We'll go to the next trainee. Your time starts now.
Yes.
Okay, you have a 60-year-old patient presenting with right-sided loin pain. He never had pain in the past. Otherwise, he's quite fit and healthy. And he presented via A&E. How are you going to evaluate him?
I'll review this patient in the A&E, preferably with the results of his urine dipstick, his observations, and if he's not too unwell, then his BMI as well. I'll take a brief history, including the events that led to his presentation to A&E, including flank pain, fever, vomiting, followed by a history of his current medications, past medical history, any prior urological interventions, his occupation, family history of any renal stones. If this will be followed by a chaperoned examination, wherein I'll review his observations again, followed by an abdominal examination. I'll specifically look for suprapubic and flank tenderness. Following this, depending upon the results that I've obtained, and I'll guide my investigations. I'll get if he's afebrile and it's just pain, then I'll not get blood culture, urine cultures. I'll just send his blood for full blood count, renal profile, urine and electrolytes, stone bloods, including calcium, urate, and then I'll direct imaging depending upon my findings. In this case, since he has flank pain, then most likely, then I will go ahead and get a non-contrast CT of the abdomen and pelvis. Depending upon his BMI, I'll opt for a low-dose non-contrast protocol or a full-dose CT protocol.
Okay. Are you able to see the pictures?
Yes.
Okay. I'm just going to scan from top to bottom.
So this is a non-contrast CT of the abdomen and pelvis. I'll first confirm the date and patient details. On the right kidney, I can see that there is a right renal pelvic stone. I'll measure the size in Hounsfield units. There is inflammation and edema around the stone, so the pelvis looks inflamed. There's very mild hydronephrosis. There's almost, just very mild hydronephrosis, no perinephric stranding on that side, and the left kidney looks normal. There are no other stones in the system anywhere. In the genitourinary system anywhere. I'm not having clear pictures of the bladder, which I'll also preferably look at. Oh, now yes. So the bladder is full and it's clear and normal. So overall, this patient has a right renal pelvic stone and a small calcification in the lower pole of the right kidney.
So very good. So what is your plan?
So now, depending on the other factors that I've gathered from history, if he's afebrile and is stable, then I will manage his pain first. I'll give him adequate analgesia. In this case, I'll start with diclofenac suppositories. If his pain is quite severe, then I'll give him 150 milligram stat dose, followed by 50 milligram TDS oral or by suppositories. Most patients prefer orally. Then I'll discuss the treatment options with this patient. Now, for this stone, the size looks approximately 1 to 1.5 centimeters when I compare it with the vertebra, which is around 2.5 centimeters, although I will measure this properly. And also, depending upon the Hounsfield units, I can offer him 3 treatment options. The first treatment option that I would offer him is flexible ureteroscopy and laser lithotripsy. The second option would be ESWL, and the third option would be PCNL. I'll first start by discussing the fact that in the advantages and disadvantages of each of these. I'll explain to him that ESWL is the only procedure which will not require general anesthesia. Now, he is fit and well, so he's quite fit for general anesthesia, so the other options are also equally good for him. Now, in ESWL, I will go ahead and talk to him about the possible success rate. Since this stone is of the size of around 1 to 1.5 centimeter, I'll explain to him that there's a 50% chance that he will not need any further interventions. But there is a possibility that he may go ahead and require further interventions in almost 50% of the cases. Yes, so I'll go ahead and explain to him that the other possible complications of ESWL would include some discomfort during the procedure, which can lead to which can be managed with analgesia. Further, following the procedure, he may continue to pass stones for some time, which can lead to episodes of renal colic. This is seen in around 2% to 10% of cases. He may have some blood in the urine, which is for the first week or so, which is quite common and is seen in all the patients. Further, there may be some injury to the kidney, which is seen around 2% of cases. Additionally, there is a possibility of some infection-related complications, which may require him to take antibiotics. This is also seen around 10% of patients. I'll use the Bowes information leaflet to guide further management. Now, then I'll go ahead and explain the other 2 options. I'll explain to him that with flexible ureteroscopy and laser lithotripsy, there's a possibility that we may have to do 2 procedures. We may not be able to get the ureteroscope into the system in the first go, as the ureter may be narrow, and we may have to stent him and come out. However, with this in mind, the success rate of flexible URS for the stone would be around 90%. And for PCNL, I'll explain to him that this is the procedure with the best success rate, but it will require us to puncture the kidney, and this increases the chance of bleeding. And very significantly, there is a 1 in 1,000 chance of him requiring a nephrectomy, and a 1 in 100 chance of requiring angioablation due to bleeding later on. So these are the brief pros and cons of each of these procedures. I will be using a Bowes information leaflet to guide to help him decide between the 3 options. And finally, I will yes. Because at the moment, all the 3 options are equally good, are acceptable as per the EAU and NICE guidelines. EAU guidelines of 2021, NICE of 2019.
Okay. Do you think that all the 3 options were equally acceptable as per NICE guidelines 2019? You want to think it over?
For a renal pelvic stone of size less than 2 centimeters, ESWL is mentioned as the first line of treatment, as the most preferred treatment.
Good. So as per the NICE guidelines, ESWL is the first choice for this gentleman. So this gentleman is quite happy with your explanation, and he is happy to go ahead with ESWL. How are you going to schedule him?
I'll check the availability of ESWL at my trust, and I will schedule him as soon as possible, preferably within the next 4 to 6 weeks. Yeah, that's all about this question. Yeah.
Okay. And what type of ESWL lithotripter you have?
We have an electromagnetic lithotripter, and I will explain to him that we'll be using a coupling gel, and the basic mechanism I'll explain to him, wherein I'll say that the electromagnetic lithotripter uses a parabolic reflector to reflect the waves onto the stone using imaging, including fluoroscopy and ultrasound. So we use fluoroscopy and ultrasound to help guide the shock waves towards the stone, and this is how we go ahead and do the procedure.
Okay. What do you mean by the F1 and F2 focal points?
So the F1 and F2 focal points are the F1 is where the shock waves are generated, and F2 focal point is the target point where the stone is, and that is where we focus the waves and try to break the stone.
Okay, patient has attended for ESWL. He is in your shockwave lithotripsy room. How are you going to proceed?
So I'll ensure adequate analgesia for the patient, because if he's not comfortable and he moves during the procedure, then it is going to be difficult to focus the stone. Also, increased respiration will lead to focus the stone. I may have to use mild sedation as well if his pain is not adequate. So after positioning the patient using fluoroscopy and ultrasound guidance, I will initially start the shock waves at the rate of 60 to 90 shocks per minute. So that is 1 to 1.5 hertz. And gradually, as this progresses, I can increase this up to 2 hertz or 120 shock waves per minute. I will monitor whether my F2 point is remaining constant and the stone is getting targeted, and some fragmentation is being noticed.
Okay,
Yes, done. Next.
Okay, very good. We'll stop there. How do you think you did?
I haven't seen much ESWL, so the practical points, I think I should go and discuss with somebody who actually does it here. Then because I haven't seen it, I think that part I didn't do very well. And initially, between the 3 options, I think it took a lot of time to decide between the 3 options and then how to explain to the patient.
Yes. So how you can improve is, I mean, the performance-wise, everything is fine. Again, communication is clear, your words are legible, you are a touch faster than the first 2 candidates, but that doesn't matter. Mainly the examiner is able to grasp whatever you say. That's more important. And
Right.
so this speed may be the maximum speed, I will say. If you speed any faster, that's it. The examiner will lose the plot, and I don't want you to waste your words but not get the money out of it. So this may be the maximum speed. I can easily say that. For others, the first 2 candidates, I'll say that's a correct speed. For you, this is the maximum speed. So mindfully try not to go more than that, and try to go maybe slightly lesser, but that's fine. The speed is good. Then initial presentation workup, that's fine. We have really taken it very fast compared to the normal 1 hour sessions what we train. This 10-minute sessions, you can see we don't dwell much on the initial preparations, and we try to take you faster. You are suffering to decide which is the correct option because you are approaching this patient more clinically. Like, for example, if this patient is really coming in front of you, and what will you do? You may really list him for ureteroscopy. You may list him for mini PCNL. You can do that. So that may be the reason you're little bit struggling to choose which is the correct method, and you kept all the 3 methods in the same platform. Unfortunately, in the exams, the answers are not just clinical expertise and presentation. It should be also backed up by the good amount of evidences. NICE 2019 clearly categorized this type of stones. The first choice is ESWL. Okay. What I will say is, when you are presenting itself, try to lean towards the ESWL, and once you know the correct size and ounce-fill units and skin to stone distance, and don't stop there. Tell I will go for ESWL as my first choice, and I will keep ureteroscopy and maybe mini PCNL as my second choice as per NICE 2019 guidelines. I'm glad from the previous two speakers you gathered to mention the year. That's a good habit. You should say these years again and again and again. Nice LUTS guidelines 2014. Nice stone guidelines 2019. At least 2-3 years. EAU, there is no other choice. 2021. It's quite obvious.
Yes.
No marks for that. Okay. And
Yes.
now, once you say that, the examiner will be happy to take towards the ESWL. For example, I thought of bringing the terminologies like ramping and the things like we need to stop after initial 3 to 5 minutes for at least 2 minutes, so that it will help in reducing the renal injury. And I thought of discussing various other things like how exactly the ESWL shockwave works, like Spalding, direct cracking, indirect energies, and I want to go a little bit in detail. But it will happen only if you really frame and play the game. And the other thing I want to show later is he ended up having a strain stress, and how are you going to treat the strain stress. Even the strain stress, if the patient is comfortable, the lead fragment can be handled by ESWL. Okay. And I want to bring in the difference between the mobile lithotripter and the static lithotripter. Static lithotripter being more powerful and more good. And you have done well with your frequencies. At least you are able to say you start with a lower frequency of 60 per minute and then gradually increase it. At least you are able to maintain that. In my protocol, we try to give suppository diclofenac 200 milligrams in the starting. That will really help the patient to avoid unnecessary sedation or any opioid drugs if needed. That's a good trick to follow. Other than that, the most other important things are the Hounsfield units and skin to stone distance, which you should have brought in when we are discussing the CT scan itself. That's a very important tool. And if the same stone is in, say, for example, lower pole, there are some other features like infundibular pelvic angle, infundibular length, infundibular width, infundibular pelvic angle less than 90 degrees, infundibular length more than 3 centimeters, infundibular width less than 5 millimeter. They are all negative prognostic factors. And try to bring some other studies other than NICE and EAU guidelines. Say, for example, lower pole one study, lower pole one study is a very nice randomized controlled trial comparing ESWL and flexible ureteroscopies. So that will really, these are all the main things stops you reaching that 8. I will still give mark 7 quite easily, but if you say I did my best, how can I make it 8? That's the main difference.
Right. Correct, Mr. Nash.
Okay. Murli, you have anything to add?
Yeah, you're absolutely right. So the speed was, I used to be having similar speed when I was practicing. So I slowly got used to that and I slowed it up. But other than that, I think it was okay. So the one trick is like for any question which the examiner asks, don't spend more than 1 minute for any question. Okay, because as the number of questions increase, your marks are going to increase. So if you keep talking, you may be talking right sense, but that doesn't count for the marks basically.
Correct.
So don't answer any question for more than, I would say, like 40 to 60 seconds for any question. And let them keep asking questions and then you can keep answering. That will improve your scoring high marks as well. Otherwise,
if I just said that ESWL is my first option, my second option would be these two, and then they can actually ask.
Yeah, they can ask you. How will you counsel for ESWL? So that will increase your marks. Otherwise, rather than you telling everything in one go, that may not be the question which they wanted to ask, because the marks are given according to the questions which they have. Like they may not have counseling for PCNL in this case. So you're exposing embolization, nephrectomies, that's not going to give you any added marks to that, although everything is right. So that is only advice. Yeah.
Right. Got it. Thank you.
Yeah, the main thing is you should reach the end of the list of questions, whatever the examiner is planning. And if you are able to reach a state where the examiner completed all the questions, two things can happen. Some examiners will say, I've done all the questions, nothing much to ask. By the time it will be only like 20 seconds or 10 seconds or maximum 30 seconds, and you'll be sitting still. And those scenarios, chances of getting 8 is very high. provided that your previous answers were incorrect.
Correct.
Very
Got it.
rarely examiner will give you a point to answer so that you really get that 8 marks nicely cemented. So in that way they can ask, do you have any studies to support your choice of ESWL? So if you bring lower pole one study and those studies, then that will be helpful. So most of the examiners will try to bring something very difficult in the end if you completed all the questions. So if you can't answer, please feel free to say I don't know, because you are already playing at 8. Okay, when you're playing at 8, don't make some mistakes and reduce your marks. Just by saying you don't know, especially in the fag end of the session, means you are not bad. You are not able to answer very difficult questions. So, but don't never answer something by intuition or wrongly. Never. Okay. And if you answer wrongly, it's 100% wrong. If you answer by intuition, I will say it's 40% wrong.
Got it.
Okay.
Got it, Mr. Shipley. Yeah.
Good.
Thanks, sir. Just a quick question.
Yeah.
So this size stone is like between 1 to 2 centimeters, if I'm right.
Yes.
So should we consider both FIRS as well as ESWL when you say this? Because
that's a practical. Yeah, that's the practical answer. But the NICE guidelines 2019 is quite clear that less than 2 centimeter pelvic stones, ESWL is the first choice. And if you see the flow diagrams and everything, first choice ESWL, second choice URS, and if not suitable, PCNL.
Okay. Yeah.
That is the main difference. For example, a well-established urology consultant, endourologist, if they attend the exam, they won't say ESWL as the first choice, because this will be a very good for a mini PCNL for them, isn't it?
Yeah.
Yeah. So till you pass, you should be able to back up with a lot of evidence and guidelines. Of course, you should answer very practically also, but you should know what is the guidelines. For example, if a student says, in our practice for this stone, we will do mini PCNL, but I am aware that NICE guidelines says ESWL should be the first choice for 18 millimeter pelvic stone, ounce per unit, 1000 or less than 1000. That's perfect. No problem. The examiner will think, okay, he's answering practically, but I want only answers on ESWL. Okay, patient wishes for ESWL, what will you do? Okay, so they will drag you to the ESWL.
Yeah, perfect.
Okay, good. Okay, we have our fourth and last trainee today, and your time starts now. You have a 58-year-old lady, quite fit, no previous episodes of ureteric colic, presents incidentally with vague loin pain to GP. GP performed an ultrasound which picked up multiple stones in the right kidney and hence referred you. How are you going to evaluate?
I'll see this patient in the urology clinic. In the history, I'll ask about her pain, site of pain, the duration of pain, how bothersome it is to her. There's any history of recurrent UTIs, any hospital admissions, medical history to see her comorbidities, medication she is on, any bowel problems she has, any family history of stones, her lifestyle features like amount of fluid intake, types of fluid that she's taking, and this would be followed by a chaperone-assisted clinical examination, general examination to see her BMI and performance status, and a focused examination of the abdomen to see for any costovertebral angle tenderness. I will review the ultrasound scan, and I will do a urine dipstick. If there is anything abnormal, then urinalysis, and check the bloods for FBC, UCNEs, EGFR, calcium urate. And I'll particularly look for the pH in the urine dipstick test. From this point onwards, my preference will be to get a CT KUB, because I suspect with the multiple stones in the ultrasound scan, because of the low sensitivity of the ultrasound scan, a CT scan will be an ideal option from here onwards.
Okay, what is the importance of urine pH?
The urine pH, it should be within the normal limits. If it is like an alkaline pH, then my concern will be whether it is a struvoid type of stone. If it is a acidic pH, then it could be uric acid stone. It also helps us in the further treatment and monitoring of the stones once the type of stone is diagnosed.
Okay, examination wise, this patient has no specific significant findings to discuss. She's well built, not too much obese, and I'm going to show you the CT scans. Are you able to see the picture?
I can see that. Thank you.
Okay.
So this is an axial section of CT abdomen, and this is a non-contrast study. As it scrolls down, I could see the most striking abnormality is multiple radiodense lesions in the right kidney, suggestive of right renal calculus. The left kidney appeared to be normal with no stones in that one. There was also parenchymal thinness on the right side. Her bladder appears to be normal with no stones. And this is the coronal section of abdomen and pelvis. Non-contrast again shows multiple stones in the right kidney. I had to confirm. Yeah, so all these stones, I mean, all these radiodense shadows seems to be connected with each other. So this is suggestive of a complete stack-horn calculus on the right side with the thinning of the parenchyma of the right kidney. So this is a sagittal section, renal stone filling the renal pelvis and almost all the calyces, and thinning of the renal parenchyma.
Okay, so
It's a reconstructed.
Yeah, how are you going to approach it?
So for her, I would like to do I have to know the function of the kidney. So I will do a MAC3 renogram to see the function and the drainage of the right kidney and to compare it with the left kidney.
Okay, why do you want to see the drainage? What are you expecting in the right kidney?
Because it is completely obstructing the calyces, and I believe it will be an obstructed kidney. But my main concern is the function of the kidney. If it is a non-functioning kidney, then the option will not will be a nephrectomy. But if it is a functioning kidney, then we have to preserve that kidney by clearing the stones.
Okay. So we can expect that this right kidney will be obstructed because of such a large big stone. So if you're not bothered about evaluating the obstruction and bothered more about the function of the right kidney, which is the best choice?
I had to go back on that one. DMSA scan is my choice here because I'm not concerned about obstruction. I'm only concerned about the functioning of the kidney. So DMSA scan.
Okay, the DMSA scan shows that split function on the right side is 41% and left side is 59%. Otherwise, there are some cortical scars on the right side, but not significant.
So I will inform the patient that this is the stack-horn type of calculus, which is completely filling the collecting system of the kidney, and the DMSA has shown that there is decrease in the function of the kidney. So it is important to clear the stones to preserve the function and to prevent any further deterioration and to prevent any further UTI or sepsis episodes. There are studies in the literature that can support my counseling, especially the Blanty and Singh paper, which has shown that there is nothing like a silent stack-horn, and there are risks of mortality with stack-horns with around 27%. There are other papers also with Teak Manitar, which showed that if we treat the stack-horn, the chance of mortality is 0%, but if we don't treat it, it is around 67%. So based on these studies, I will tell her that it is important that we have to treat this stack-horn. I will support my, I'll tell her the options. The best option is percutaneous nephrolithotomy on the right side. The alternatives could be a sandwich treatment with a combination of ESWL or ureteroscopy, but those alternatives are not ideal in her case. And I will support my counseling with the Bowes information leaflet.
Good. And you are arranging this patient for PCNL. What type of PCNL you are going to perform?
So because this is a complete stack-on calculus, I will plan for a standard PCNL. So I will tell her about the risks and benefit of this procedure. The benefit of the procedure is PCNL, the standard procedure, has got the complete, the best stone-free rate. The risks involved are in the risk of surgery, early and late, and the risk of anesthesia. The early risk involvement are the difficulty in access, need for multiple access, possibly puncturing the adjacent organs like bowel or entering the pleura, risk of bleeding, which might need transfusion in around 2%, which might need angioembolization in 1%, and the need for nephrectomy, which is very rare. And then the postoperative recovery with the nephrostomy, chance of pain, and so this will, and this is my initial approach to her.
Okay, how are you going to plan your puncture?
So in her case, because this is a multiple puncture, in my trust we use the supine PCNL. So the initial puncture will be a lower pole puncture, and then we can use a flexible nephroscope to remove to gain access to the other calyces. If it is difficult and if it is really packed, the calyces are really packed with the stone, then we can use multiple punctures like upper pole puncture, so that we should try to clear the stone, get a full stone clearance in the first attempt.
Okay, what will be your choice of lithotrite?
For this one, I will use the ultrasonic lithotrite, but I am aware that laser lithotripsy is also an option.
Is it possible to combine two type of energy sources?
Yes, we can. Because if I'm using a flexible nephroscope for the access to other calyces, I can, the better option is a laser lithotrite. So in this case, because it is a very complex anatomy, very complex stone configuration, I'll make sure that both are available in my theater during the procedure.
Okay, so what type of lithotrite you use? What is the make?
For a standard PCNL, I use the ultrasonic lithotripter, which has got a combination of ultrasound fragmentation of the stones and a suction. So that's my usual practice.
Okay. Any advantage of having a combination of pneumatic and ultrasound lithotrite?
Yeah. So the advantage of pneumatic and ultrasound is the stone fragmentation is much better, and the clearance is also much faster if you combine pneumatic with ultrasound and suction.
Okay, let us assume that you made 2 punctures, and with the help of the flexible nephroscope or the cystoscope, which is used as flexible nephroscope, you achieved a good clearance. What is your exit strategy?
So I will keep a nephrostomy, and we'll make sure that the patient is safely transferred. We'll monitor her for pain, development of any features of sepsis, continue the antibiotics for at least 2 more doses, and then monitor the urine output and the nephrostomy output.
Okay, that's good. It's time. It's in Murli?
Yeah, 10 minutes.
Okay, thank you. Thank you. How do you feel?
Thank you.
Any inputs before I give the feedback?
Yeah, definitely. The renogram, I mixed it up. So I knew, in between, I knew that it's DMSA. I should have come back at that time rather than continuing with the MAC3.
Yeah.
And
good. So my view is, number one, good communication, good stable speed. Guys, I'm mentioning this because it's very important that at least we discuss the way by which you're talking once in a while, so that you guys are making the correct pronunciation and correct speed, because the marks are given for communication, knowledge, and application of knowledge in your clinical scenario. So I'm sure there won't be any problem with anyone, but of course, if there is someone who has some issues, it's nice to work on it. So no problem with communication, and I'm happy with progression, Anish. Preparation is fine. A little bit cautious towards the infections. That's good. and going through the previous ultrasound and going for CTKUB, that's good. I thought of asking you what is the role for Ct Eurogram in these kind of scenarios, but there is no time. But the Ct Eurogram has some specific roles, like for example, horseshoe kidneys or calyceal diverticula, you can use it. As per the AU guidelines 2021, CTKUB is more than enough for most of the PCNLs. And I'm happy with your preparation, Bow's information leaflet. And when you say supine PCNL, there is a small school that for complete stagon like this, prone PCNL has a touch of better clearance, but I believe in supine PCNL, so I will also go for supine PCNL. Nothing major difference in that. I wish you to give the examiner the confidence that you are quite clear in the steps of the PCNL. So I was expecting like retrograde catheter placement and whether you are using an ultrasound guided puncture or image intensifier guided puncture, whether it's a bullseye or triangulation technique. Nothing wrong in skipping them, because sometimes the radiologist may be doing it, which you said. And these kind of complete stagons will definitely serve by having at least 2 punctures, if not 3 or more. And my choice of puncture for complete stagon, male or female, is the upper pole puncture, because upper pole puncture will really result in good clearance of upper pole calyces, pelvis up to the PUJ, and then you for the lateral calyces, and even you can reach the lower pole from upper pole easily. And then the middle calyces, you can even just do a puncture and push the stone into the pelvis. And very rarely complete stagons can be handled completely by one puncture if it is an upper pole puncture. I'm not very comfortable in your choice of lower pole puncture, because lower pole puncture will give good lower pole and pelvic clearance. You may not be able to reach the PUJ if there is something like a hook shaped stone entering into the PUJ from the lower pole. And sometime, especially in women, the bump in the gluteus will make your life very difficult in supine PCNL in getting the angle even to reach the upper calyx. So the success will be more if there is an upper pole puncture. And my choice of lithotrite is something, a combination of pneumatic and ultrasonic lithotrite, because it gives good energy. We can break the stone, we can keep the suction to keep the pelvic system empty. And now we have, I don't want to say the trade names, but we have excellent products which clearly has a very good efficient, and you can adjust both pneumatic and ultrasound in a very nice manner to keep a kind of an average usage of both. We have pedals with one pneumatic, one ultrasound, and if you press in the center, it will press both pneumatic and ultrasound together. So I was really expecting you to select that energy source, and I'm not even expecting you to say laser, because that's not very ideal unless if you use nephroscope for a calyceal access. And so selecting only ultrasound is not a very strong choice, but I understand maybe your individual practice. And exit strategy, definitely nephrostomy for these big stones is not fair in discussing tubeless. And if you think that maybe some fragments passing down the ureter, nothing wrong in keeping a antegrade stent and nephrostomy, so that you can remove the nephrostomy, and the stent will help in clearing the fragments in the future. And a few other things you can mention is like prolonged positioning, so you may have to top up the antibiotic if there is any need. And something like preparing the patient with an anesthetic fitness before starting, so that we are sure that patient doesn't require any ITU support. And upper pole puncture, stagon stone, while completion, it's nice to use the C-arm to make sure that there is no signs of any pleural injury, pneumothorax, etc. And if you have an ultrasound or radiologist nearby, they can also help to image the lower part of the lungs and pleura with ultrasound. So a lot of things, but I expected at least 50% of what I said you can squeeze in. There's nothing much space there in the 10 minutes. So as you see that in the actual exam scenarios, the dwelling in the physical examination history will slowly be reduced weightage, and more weightage in actual investigations, and more details into treatment and follow-up. Okay?
Okay.
Good.
Thank you.
Any inputs from you, Anish, before you go?
I mean, there is not much other papers I have to mention except from Blandy and Singh and Teak Manital for PCNL, isn't it?
Yeah, you can mention Gladico Valdivia papers for the supine PCNL positioning maybe. And
Okay.
otherwise, I think nice guidelines 2019 you can bring in here and there.
All right. Okay.
Okay. So we have 4 trainees. Any other trainees as any other views on all the 4 scenarios? I can have some final comments if you have before we conclude. Okay. If there is nothing much, Murli, you want to add anything, please?
No, yeah, so it was really good discussion. The one thing which they commonly ask is the equation for the formation of stack on stones. Like they ask you to write down the equation, so you should be well versed with that equation because you should not waste time in that. It just needs to be just a tick mark in that. So that equation is very important. Other than that, I mean, the papers reported were fine. Your technique of PCNL and everything was, I mean, DMSA versus MAC3, we know now which is the right option. So yeah, everything was fine. It was good.
Thank you. Thanks.
Okay, good.
Great.
Can I ask a question, please?
Yes, please.
Yeah. So in staghorn or large stones, can I say like I would like to know the Hounsfield unit, radiopacity or radiolucency rather, and urine pH and uric acid. If it is inclining towards a uric acid stone, I would treat with chemodissolution before moving on to other intervention. Is it correct?
Yes, that's absolutely acceptable. Anish did mention about the urine pH and all stones, even if it is for ureteroscopy, it's nice to know about the Hounsfield units. And if the Hounsfield units are supporting the uric acid and if the blood's also supporting increase in urate, there is nothing wrong in starting this patient on potassium citrate and other medical dissolution treatment. And even if you list the patient, that is nothing wrong in re-imaging a patient 1 or 2 days before or on the day of the procedure to see how far the stone volume has decreased. Yes, there is a good role for dissolution. It's quite rare for these staghorn stones to be of possible, but quite rare, which most probably it will be like a calcium monohydrate stones with Hounsfield unit like 1200, 1500 in that range.
And in the first case, there was a bit of hydronephroureter. So in that case, can we still go for conservative management, or you want to do a ESWL at least for the first case?
We can still go because the reason is any stone will have some obstruction. We need to have multiple parameters: how much the pain is tolerable for the patient, what is the size of the stone, what is the position of the stone. As we know, the lower ureteric stones, medical expulsion has quite high success rate. If they are closer to VUJ, the success rate is quite high. The stone is quite closer to the VUJ. So medical expulsive therapy is still possible. If you have a on-site lithotripter, yes, there is a role for ESWL, and if the patient is very symptomatic, we need to do primary ESWL or primary ureteroscopy within 48 hours. That's the NICE guidelines 2019.
Yeah. All right. Okay. Thank you.
Okay, guys. Good. We had a nice discussion of 4 major scenarios. There are some other scenarios where you may be dragged on to discuss the metabolic evaluation and a few other things. Of course, if time permits, we will do it in our second round of the mock vivas. We will try to do one table with selected 4 scenarios, and I'm sure we will have enough time before your exams to do the same table again. In that case, I will cover the rare scenarios also. If there are no further questions, we can call the class dismiss.